welcome everyone and I introduce Dr. Kalpana, the coordinator, to start the program. Dr. Kalpana.
Thank you, ma'am. Good evening, everyone. I welcome you all for the wonderful Bodhana 5th session, which has been started by TNFOG team with great efforts from Sampath Kumari madam. We have learned teachers here and experienced examiners who can share their knowledge, which would be really helpful for the students. Now I invite Anjalakshi ma'am. Sampath Kumar ma'am, do you want to tell anything?
Anjalakshi madam, welcome.
Anjalakshi ma'am is the founder president of TNFOG, past president of OGSI, governing council member of DIPSI, PhD in pregnancy diabetology from MGR University, recipient of Best Doctor Award, retired professor of Medical College, presented number of papers in national international conference. Madam has done research work in GDM diagnostic test and OHA in GDM. Original work on single test procedure for the diagnosis of GDM. Guidelines of Government of India endorsed by WHO and FIGO. Over to you, ma'am, for your welcome address.
Hello. Thank you, Dr. Kalpana. I'm audible, ma'am?
Yes, madam. Yes, madam.
Okay. I welcome the teachers from that is the internal teachers as well as the teachers from the outside university for this Bodhana program, and students to make use of this program from the great teachers who have got a very wide experience being examiners. So you can learn a lot of things from the examiners. So I request and also welcome the examiners for this Bodhana program, and kindly carry on. Thank you.
Good evening, Anjalakshi.
Hello, Jayashree. Hello. Hello. There was problem in connection, Jayashree. So I joined late. Okay. Welcome, Jayashree.
Thank you.
Chitrakala, shall we have the slides? We have Sasikala ma'am, who is a chief HOD of
Kalpana, first today, Arubadai Veedu Medical College PGs will present the case.
Okay, ma'am.
Students will present. Then you will.
Okay. So great effort had been put on by Arubadai Veedu HOD and chiefs for preparing the student for this wonderful session. Thank you so much, ma'am. We have Sasikala ma'am as an internal, who is graduated from Madurai Medical College, assistant professor, associate professor in Government Rajaji Hospital, Madurai, and retired as professor HOD in Teni Medical College. Now, madam is professor HOD, Manakula Vinayar College previously, and at present, madam is the HOD of OG department in Arubadai Medical College, Arubadai Veedu Medical College, published many papers in national and international journals. And madam is a UG and PG examiner in Tamil Nadu, Kerala, Andhra Pradesh, and Karnataka. She is also a Senate member of MGR University, member of PG Board of Studies, Pondicherry University, external expert in PG Board of Studies of Sri Balaji Vidyapat University at present. Welcome you, ma'am. Next, we have Dr. Sendil Kumari Arumugam. Madam is a professor and head of OG department, MGMCRI, Puducherry, and she's a postgraduate research guide since 2010, published 30 publications in national and international journals, and welcome you, ma'am. We have external examiners, Jayashree ma'am, who is the HOD, Savita Medical College, Chennai, retired director in charge, IUGR Chennai, past president of OGSI, presented papers in national, international conferences, recipient of Best Teacher Award from MGR University, felicitated by the Oncology Committee of OGSI. Welcome you, ma'am.
One more person, Dr.
Yeah.
Rajalakshmi.
Another external examiner is Rajalakshmi ma'am, who is a professor, RSRM Hospital, presented many papers in the conference. Welcome you, ma'am. Now the presenter is Nikita, who is a final year OBG PG, Arubadai Veedu Medical College. Welcome you, Dr. Nikita. We are waiting for your wonderful presentation.
Kalpana, another one presenter will be there. Nikita and
Dr. Nandini, who is also a final year postgraduate in Arubadai Veedu Medical College. I welcome both the PGs for your wonderful presentation and excellent discussion and learning from our excellent teachers.
one will be presenting on early onset and another will be presenting on late onset. I think you have wonderful 4 examiners. Please make use of it. All PGs ask many doubts. Yes, Kalpana.
I request the presenter to start the presentation.
One by one.
Good evening, ma'am. Is our screen visible, ma'am? Can I proceed?
Yes. Yes, ma'am.
Good evening, all. Proceeding with a case presentation on IUGR. Mrs. N, 27-year-old female, wife of Mr. B, residing at Puducherry, homemaker, belonging to socioeconomic class 3, booked the case of Kartukuppam PHC. She is a primary gravida at 30 weeks plus 3 days of gestation, a known case of gestational hypertension since 26 weeks on antihypertensives, with a clinical evidence showing query FGR, referred to our hospital from our PHC for the first time for further management. LMP was on 11th May, EDC was on 18th to February. She was able to perceive fetal movements well. There was no history of headache, blurring of vision, reduced urine output, pedal edema or epigastric tenderness. No history of bleeding PV or leaking PV or lower abdominal pain. No other specific complaints. First trimester history, present pregnancy, spontaneous conception, confirmed by UPT after 45 days of amenorrhea. Folic acid tablets were taken regularly. There was no history suggestive of any drug intake other than folic acid. There was no history of exposure to radiation, no history of fever with rashes, no history of first trimester spotting or bleeding PV, no history suggestive of hyperemesis gravidarum. Dating scan was done at 9 weeks plus 5 days of gestational age. Dates were corresponding to 9 weeks plus 3 days, CRL 2.8 centimeters.
Nikita, 1 minute. Chitrakala, Sendil madam.
Yes, ma'am. Yes, ma'am.
Unmute panna mudiyala.
Yes, ma'am.
Indoor teacher. Yes. Yes.
Thank you, ma'am.
Yes,
Hey,
ma'am.
proceed, ma'am. Proceed.
Can we proceed? Yes, ma'am.
Yeah.
Dating scan was done at 9 weeks plus 5 days of gestation. Dates were corresponding. All routine basic antenatal investigation at the time of booking were done and were found to be within normal limits. Second trimester obstetric history. She was fully immunized against tetanus toxoid. At 13 weeks, NT was found to be within normal limits. Quickening felt at 20 weeks of gestation. Iron and calcium supplements were taken regularly.
1 minute. Do we put it in the second trimester?
Ma'am?
Dating scan. Do we put it in the second trimester?
Ma'am, dating scan was done in first trimester, ma'am.
Then why do you add it in the second trimester?
No, ma'am, it is first trimester history, ma'am. This is first trimester history, then followed by scan. This is second trimester history, ma'am. NT was done in 13 weeks, ma'am.
Okay.
No, madam is asking.
First trimester. First trimester extends up to
13 plus 6, ma'am. NT can be taken up to 13 plus 6, ma'am.
No, you include that in the first trimester. That's what she is asking, no?
Okay,
First
ma'am.
trimester.
You can include up in the first trimester, ma, up to 14 weeks now that they say you can include it at the first trimester. That is
Okay.
what madam is saying. Okay, ma.
Quickening felt at 20 weeks of gestation. Iron and calcium supplements were taken regularly. Anomaly scan was taken at. Ma'am, this is Nandini, ma'am. Ma'am, presenting is Nandini.
Nandini, okay.
Yes, ma'am.
I am Dr. Rajlakshmi. Madam,
Ma'am, good evening, ma'am. Yes, ma'am.
good evening. Anjalakshmi, madam, good evening, madam.
Good evening,
Good evening,
Rajlakshmi.
okay. And Nandini, I would like to ask you, what is the importance of doing a dating scan?
Ma'am,
you do
here, ma'am, for confirmation of dates first, ma'am, because as this is the case of IUGR, so we have to confirm dates first. Then other indications for doing dating scan are, we have to confirm that it is an singleton pregnancy. In case of a wrong date where LMP was not sure, in a case of where we suspect, is there any first trimester history suggestive of bleeding or spotting PV, ma'am?
Okay, what is accuracy? Accuracy in first
Yes,
trimester
ma'am.
of accuracy of first trimester scan in dating, and second trimester, why can't we do? What is fallacy or variability? And
Okay,
again,
ma'am.
third trimester, will you take that measurement for a dating scan?
Ma'am, in first
What is the
trimester,
difference?
yes, ma'am, less than 10 weeks, if we take the disparity, we can accept this plus or minus 5 days, and it is more accurate. In 10 to 13 weeks, the 6 days scan, plus or minus 7 days disparity is accepted, ma'am.
Okay.
After 15 weeks to 20 weeks scan, plus or minus 10 days it is accepted. After 20 to 30, plus or minus 14. After 30 weeks, plus or minus 21 days is accepted, ma'am.
So there's more variability in the third trimester. So if any patient comes with a third trimester scan or late second trimester scan, we cannot use it for a dating scan. We have to combine and we have to give her the gestational age, or you have to go by the epiphysis. Okay.
Yes, ma'am.
Please continue.
Anomaly scan was done at 20 weeks and there was no gross congenital anomalies seen. Obstetric history in the second trimester, screening for GDM by DIPSI method was done and found to be within normal limits at 24 weeks. At 26 weeks of gestation, patient was diagnosed as gestational hypertension with a BP of 140/90. She was started on labetalol 100 mg OD. Urine albumin at the time was nil. HB, PCV, platelet, RFP and liver function tests were within normal limits. BT, CT, thyroid profile were repeated and found to be normal. At 30 weeks of gestation, on clinical examination, her uterus was corresponding to 26 weeks with a growth lag of 4 centimeter in symphysis fundal height. Hence, she was referred to her hospital for further management. Menstrual history.
Nandini,
One
can I
more
ask you
minute.
something? Sendhu
See,
Kumari here.
you said you have done the congenital anomaly scan. Okay, did you do that? What else are you supposed to see?
In congenital anomaly scan, ma'am?
No, along with that, it is mandatory you do that, and it has an application in this case as well.
Doppler study, ma'am. But it was,
before going to Doppler.
ma'am,
targeted
anomaly scan.
What else should be done? RCOG recommendation is also there. It is mandatory. You have to look for the placental localization. Did you say that?
Yes, ma'am.
Because if it is going to be a placenta previa or something like that, then probably that could also be a repeated bleeding. It can be a cause for this IUGR, isn't it?
Yes, ma'am.
Nandini, I have a question for you.
Yes, ma'am.
Can you go back to your previous slide? Yeah, if you were the consultant, you have a patient at 26 weeks, gestational hypertension. Is this early onset or late onset hypertension?
It is early onset, ma'am.
Early onset hypertension. So we are going to face problems in this pregnancy, isn't it?
Yes, ma'am, definitely, ma'am.
So when do you want the patient to review back? Do you want the patient to come back after 4 weeks, or you want the patient to come earlier?
Earlier, ma'am. Because being diagnosed with gestational hypertension as early, there are more chances for developing IUGR in later pregnancy. So I will increase the frequency of visits. Like I will like to review her every 2 weekly once, ma'am.
Yeah. So have you seen her at 28 weeks? Probably would have been.
Sorry to interrupt. The case was seen at a PHC, ma'am. At 26 weeks, they have diagnosed it is a case of a gestational hypertension. They have started there on labetalol and they have referred the case to Kadalur GH. The patient didn't go there and she has gone to the hospital at PHC 4 weeks back, and from there she has
The history, but generally, if you would manage, Nandini, if you would manage, then you would ask the patient to come in 2 weeks' time, isn't it?
Yes, ma'am. Yes, ma'am.
Okay, right, go ahead.
And another thing, we should not go by that 140/90 because already she has been started on levotinolol and she is under the effect of the drug. That is why the BP on examination at that time is 140/90.
Yes, ma'am.
You cannot say whether it is a severe hypertension or whatever it is. With levotinolol, she is still 140/90. Okay, so you should not be fooled by that reading. Should not think it is a mild one and she would not require the medication.
And you should not write that she is gestational hypertension here itself. See, this patient is quite early. We have picked this patient up. So she could be a chronic hypertension missed earlier also. So you just say she was diagnosed of hypertension during this current pregnancy.
Okay, ma'am.
No, on perusal of the records, they have recorded the BP, ma. At the time of booking and even 20 weeks, they have recorded it was a normal, she was normotensive. She was a booked case at the PHC. So they have the previous, on perusal of the records, it has been found to be, it has been gone there and they have recorded it was a normal blood pressure.
Okay, so her previous recordings have been normal.
Yes, on perusal of the records, we saw that the previous records were normal.
Okay. Right, go ahead.
Yes, ma'am. Menstrual history, previous cycles were regular, 5/28 cycles. 3 pads, normal flow, not associated with any clots or dysmenorrhea, LMP on 11 and EDD on 18th February. Marital history, she was married since 3 years. It was a non-consanguineous marriage. Past history, she was not a known case of type 2 DM, congenital heart disease, anemia, epilepsy, bronchial asthma, or autoimmune disorders. Family history.
Specifically type 2 DM you said? Why specifically you have said type 2 DM?
Because over DM with vasculopathies are more prone to develop IUGR babies now.
So the vasculopathy will not occur in type 1?
Less likely to be.
No. Okay. So you say no history of diabetes.
That's all.
Okay.
There is a question in the chat box. When does the role of inpatient management arise in gestational hypertension?
Yes, Nikita, answer.
When does the role of inpatient management?
Ma'am, when we have admit her.
Ma'am, when patients shows any imminent signs like headache, blood infection, reduced urine output.
See, that is for a patient whom you have evaluated and stabilized. So for any patient to whom you are suspecting hypertension, you want to keep her under observation, we have to do all the investigations and then only we can send her home. So you have to confirm whether she is really a case of preeclampsia, and then you have to admit her for evaluation.
Do a basic lab investigations and evaluate her.
So you don't wait for imminent symptoms to develop.
She has been admitted. You just say she has been admitted and she has been evaluated.
Okay. One more question from my side. Since you brought up the topic of overt diabetes and vasculopathy, what are the high risk factors which predispose to a growth lag or early onset IUGR? Maternal, or what are all the risk factors which come to your mind?
The risk factors can be of major and minor. Major maternal disorders like type 2 DM with vasculopathy, then chronic hypertension, antiphospholipid APLA, SLE, inherited thrombophilia, then even the maternal age. These are the major risk factors, ma'am. Minor will be the paternal age. Now, coming to the maternal thing, ma'am, any major is age greater than 45 years of age and smoking, using about 11 cigarettes per day, cocaine abuse, heavy physical exercise. Minor will be and then the BMI less than 20 and BMI greater than 25.9, ma'am. And the minor risk factor will be age at 35 years of age. Now, coming to the obstetric history, previous past history of any low birth weight or small for gestational age abuse, that is major. The minor will be previous history of PIH will also be a minor, ma'am. Then coming to the medical history, as she told, it is any chronic hypertension diabetes vasculopathy, AFLA, inherited thrombophilia, maternal SGA. Minor will be paternal SGA. And coming to the present complication, any threatened abortion is heavy menstrual bleeding, then pre-eclampsia, antepartum hemorrhage. This will be the major risk factor, ma'am.
Divide it into maternal, fetal, and placental. Then it will be easy for you. Maternal, you can talk about the uteroplacental insufficiency, the conditions which renders the blood hypoxic, and talk about the nutrition.
Malnutrition.
Yes, ma'am.
Not jump from one thing to the other. Fetal factors, placental factors, maternal factors. And maternal factors should be, you have to discuss under those conditions which differ with the uteroplacental perfusion, nutritional factors, and the maternal causes which renders the maternal blood hypoxic. That comes under bronchial asthma, a chronic congenital heart disease, okay, patient living in high altitude. So all this you have to segregate and answer, ma. Okay.
Ma'am, can I proceed, ma'am?
Yeah.
Family history. There was no family history of hypertension and diabetes at twin pregnancy. Personal history. She consumes mixed diet. Bowel and bladder habits normal. Not a smoker or alcoholic. Sleep pattern was normal. Patient was average in size at the time of birth. General examination. General condition was fair, afebrile. She was moderately built and nourished. Height 166 centimeters, weight 56, BMI 20.7. At 30 weeks now, she is 166 centimeters, weight is 62 kgs, and BMI is 22.9. Weight gain during present pregnancy is 6 kgs. Pulse 86, BP of 130.
What is the normal? I like 1 minute. What is the normal weight gain? Every month she comes for antenatal care, no? So what is the weight gain in the first trimester, second trimester?
The weight gain during pregnancy.
When she should be referred?
Yes, ma'am. The weight gain during pregnancy specifically depends upon the pre-pregnancy weight and her BMI. If a patient has underweight, like BMI of less than 18.5, then the normal weight gain should be of 12.5 to 18.5. If her BMI is between 18.5 to 24.9, then the normal weight gain, that is during pregnancy, should be of 11 to 18 kgs, ma'am. If she is overweight, that is between BMI of between 25 to 29.9.
What is 11 to 18 kg? 18 kg, what is 18 kg?
Ma'am, 11 to 16 kgs, ma'am.
Weight gain 18 kg. Yeah.
11 to 16 kgs, ma'am.
11.
Not 16, 18 and all. Where is this one?
You should not say that is an overweight, no.
18 kg and all.
11 to 16, ma'am. If it is, she is undernourished, that is BMI less than 18.5, then she should get 13 to 18 kgs, ma'am.
18 kg, which book sells 18 kg? See, normally what should be the weight gain? She goes to the, normally our patients go to the PHC or a private practitioner. So every month they are going. Every month what should be the weight gain?
For a normal BMI, what should be the weight gain? Anything
11 kgs, ma'am. 11.
Every month she is going for a checkup. No, we don't wait for
yes, ma'am. In the first trimester, there won't be any
no weight gain. Okay.
Yes, ma'am. In the second trimester, 5 to 6 kgs. In the second and third trimester, she should gain 5 to 6 kgs, ma'am.
That's okay. We are not going to wait for the entire second trimester to finish. Every month I'm asking what should be the weight gain. So she comes to our OP, no? So when we compare,
1 kg, 1.5 kg, what should be the weight gain?
What is the rate of weight gain? It was very
kg
important. 1 kg per week.
Very simple question, no? Per month or per week? Per week, how much she should gain?
See, per month she has to gain 0.5 kg per week. Okay. So anything exceeding that, or if it is lower than that, it's again a simple tool to check whether if the baby is not gaining weight. Okay. And also a PAH, any pedal edema, also will add on to the weight. Okay. So this should be the thing.
Excuse me 1 minute, ma'am.
2 kg per month, it is abnormal. Okay. It should not exceed more than 2 kg per month. Okay.
Nikita, one more question or clarification. You said her birth weight is average. Patient's birth weight
Ma'am,
is
sorry, ma'am,
average.
your voice is breaking. Ma'am, we couldn't hear you, ma'am.
Patient's birth weight, you said average, no? In your history presentation, you said the patient's birth weight is average. Did you say that?
Show your
Ma'am, yes.
previous slide.
Yeah, she told average.
Yes, ma'am.
Here,
Patient was
last
an
slide.
average size
What is the significance of that?
yes, ma'am. Maternal small for gestational age is a major risk factor for having IUGR babies, ma'am. Paternal
Not
is minor risk factor, ma'am.
SGA baby.
Ma'am?
SGA baby.
SGA baby, yes, ma'am. SGA baby.
See, there's a very simple, small mothers produce
Small baby.
babies. Okay, right.
Yes, ma'am.
Okay.
Thyroid, clinically normal. Bilateral breast, soft and nipple normal. Systemic examination was normal. Abdomen examination.
Expect to see in the breast. In case of FGR, does it talk about the severity of the condition? Examination of breast, does it throw any light?
Yes, ma'am. Yes, ma'am. The lag of 4 centimeters of more.
No, breast.
Breast.
Breast
ma'am.
examination.
Yes, ma'am. She is primigravida, ma'am. So there can, as a routine part of our examination, we should assess our breast examination also because she may land up in.
To this placental insufficiency, FGR, does
What
it
can happen?
What can happen in the breast? What can be there? Normally, what do you see in the third trimester if you press? Is it normal if you press something comes out?
Secretions, ma'am, will be there, ma'am.
No, be specific about the secretion, type of secretion.
Colostrum, ma'am.
Yes, colostrum. Suppose you have frank milk. Does it throw any light? Does it tell about the, it is an ominous sign?
It tells that mature.
No, ma.
She has given the
Galactoria
answer
does it
already. She has given the answer.
Does galactoria signify anything? Madam is asking.
Galactoria.
Galactoria, the third trimester.
She's
in
Here,
pregnant
don't call it
at
as
the moment,
galactoria.
isn't it? And she's having milk secretion. What does it mean to us? Is the placenta functioning normally or is
The maturity of the placenta is towards, ma'am. The grade 3 of maturity of placenta. Placenta functions very less, ma'am. That's why, because there will be an because of decreased estrogen production, there will be a negative feedback mechanism which leads to this hyperprolactinemia, ma'am. I mean, sorry, galactoria.
Prolactin is already high. Only the block is taken off.
Block is taken up, and that block is taken up due to this
that
maturity
is
of the placenta.
We
So
don't
finally, what does it mean to us?
Ma'am?
Finally, what does it mean to us?
The placenta is under functioning, ma'am.
It's not functioning adequately.
Placental insufficiency.
Okay.
Say placental
insufficiency, ma'am.
That is one of the corroborative findings, okay? To say that something is going wrong. Right. Okay, go on.
So fetal compromise, we have to terminate. Time to deliver.
Okay, ma'am.
Okay.
Systemic examination. CNS clinically normal. CVS S1, S2 heard, no murmurs. RS bilateral RNC present, no added sounds. Abdomen examination in inspection. Abdomen longitudinal distended, tinea nigra plus. No scars, dilated veins or hernial orifices are free. Palpation. Uterus was 26 weeks of size. Fetal parts palpable. FHR was 148 beats per minute. Symphysis of fundal light 26 centimeter. Summary. She is a primigravida, 27-year-old primigravida at 30 weeks plus 3 days of gestation. A known case of gestational hypertension since 4 weeks. On tablet labetalol 100 milligram OD with query IUGR for further management. So since she is the case of...
One sec. See, now you have examined the patient. She should be 30 weeks. She's only 26 weeks. There is a lag. So any other leading question you want to do? Any other further examination would you like to do? Uterus is smaller than the period of amenorrhea.
Yes, ma'am. First, I would like to confirm dates, ma'am, whether dates are normal.
Okay.
Then clinically, I will check for...
so following the abdominal examination, what other examination you have to do? See, uterus is smaller. What and all comprises the for the distension of the uterus, uterine distension. The baby, then what is the other component?
That's what.
Liker, ma'am.
Liker. So.
Yes, ma'am.
Hmm.
So I'll check for clinical liker, ma'am. It is adequate.
History. What you want to ask the patient? Any?
History. I will ask the
regarding the liker.
Yes, ma'am. Things which will lead to oligohydramnios, like
no, any draining you should ask, and also you have to look for any draining.
Yes, ma'am. Draining, leaking PV. Yes, ma'am.
Okay. So you have to local examination. You have to look for that. Okay. Okay. Now just tell me what are the.
Another thing I wanted to add, Nandini, when you present here, you can, instead of saying directly IUGR, you can say the fundal height is less than the period of gestation. So I'm thinking in terms of IUGR or oligohydramnios. It could be either, isn't it?
Okay, ma'am.
Okay. Tell me some of the conditions where the uterine height is smaller than the period of amenorrhea. First thing you told was wrong dates.
Wrong
then
dates.
Next oligohydramnios. Next, of course.
Then constitutionally small features, ma'am.
IUGR. One more thing.
Constitutionally small features, ma'am.
Okay. One more.
Any more?
IUFD also. IUFD.
IUFD.
FD. Just for them. Okay. Carry on.
Since she is a case of gestational hypertension, I would like to repeat PIH investigation HB 10.9, which I was repeated, and this is the report, ma'am. HB 10.9, PCV 29.3, platelets 2.6, RFT, LFT normal, urine albumin nil, sugar nil. Then at 30 weeks, DIPSI 123 milligram per deciliter, urine PCR 0.1, blood group A positive. Then the fundal examination was done. And it was normal. Then I have sent her for USG with Doppler, ma'am. The USG report is fetal well-being scan was done, that is at 30 weeks plus 3 days. Presentation was cephalic, placenta, posterior, it is not low-lying. AF5 was 9.5 centimeters.
Findings. Ultrasound findings. Ultrasound.
Ma'am, this is my ultrasound finding, ma'am.
You are telling about Doppler, ma?
Yeah, I have put, ma'am. I have put here, ma'am. A single AFI. After that, estimated fetal weight was 1.3 plus or minus 199 grams. It was at 4th centile, and abdominal circumference corresponds to 26 weeks plus 2 days. It was less than 3rd centile. Then umbilical artery Doppler was more than 94. And uterine artery Doppler was more than 95. Middle cerebral artery was less than 10 centile. CPR ratio was at 5th centile, ma'am.
Uterine artery Doppler, what did you do in that? Umbilical artery, uterine artery Doppler. What is the
index, ma'am? PI, ma'am.
PI, okay. So, how is it important here? What else you should do in an early onset of FGR? More than
ma'am, your question, ma'am, like other than
what is the role of CPR and umbilical artery in early onset IUGR? Is it useful, or do you want to do anything else?
Ma'am, in early onset IUGR, I would like to do ductus venosus also, ma'am, but to decide the termination of pregnancy, it was the prognostic factor, ma'am. It depends.
What else
prognostic factor, or it helps you decide method management?
Management, yes, ma'am.
Okay, what else can you do? You are going to be, going deeper into Doppler. What other Doppler finding is going to be of use in early onset FGR?
Ma'am, like the criteria, ma'am, Delphi, like we can assess whether it is early onset or late onset, ma'am. With the solitary, and the solitary factors will be AC or estimated fetal weight less than the 3rd centile, or absent end-diastolic flow in the umbilical artery. This is the solitary factor, ma'am. The contributory factors can be of 2 out of these 3, ma'am. AC or estimated fetal weight will be less than the 10th centile. Uterine artery PI more than 95th centile, or umbilical artery PI more than 95th centile. This, if the gestation age is less than 32 weeks, ma'am. This all will tell me that she is the early onset IUGR case, ma'am.
And not
Or not late, or not SDA, ma'am. I mean,
SDA.
constitutionally small.
Okay, that's what I'm asking. What other improvement in the Doppler? What other Doppler that is coming up?
Aortic
That
ischemia, ma'am.
Yes, that is going to be of use.
Yes, ma'am. Aortic ischemia.
So,
But-
what is aortic isthmus? Where is it situated?
Ma'am, it is a joining artery from the right ventricle to that of the aorta, ma'am. So no, ma'am.
What is aortic isthmus? So you need to know about it because so many studies are coming.
The place where it joins where?
It aorta, ma'am, descending.
Yeah, it is in the
aorta, ma'am.
Yes,
it is on aorta. Where? Where is the location?
That is the location. It is between the ductus arteriosus and the left subclavian artery. The place where the ductus arteriosus.
Okay, that location. Okay, ma'am. Okay.
Arch is
Between
there,
the
no?
left subclavian
The
artery.
first one is the left subclavian artery, and just below that, the ductus arteriosus is going to join the aorta.
So it is
that
between this.
narrowed. That is the isthmus of the aorta. So the flow over there again has significance.
Yes, ma'am.
Can reflect the.
What it can reflect, ma?
Ma'am, any reversal, it reflects that the output, ma'am, like it is equally predictive. Like if there is an MCA artery pulsatile index less than that 5th percentile, the simultaneously aortic isthmus will act, ma'am. Like if there is any.
Nandini, get the question. What madam is asking? What does it reflect? When this aortic isthmus reversal occurs, how does it go?
Cardiac compensation will be.
No, ma, it is the neurodevelopmental delay can occur. Whenever there is an aortic isthmus Doppler abnormality, when they are going to follow the child, it has been found out at the age of 2 years, there is a delayed neurodevelopmental. Okay. So it has got a prognostic significance. The CPR ratio and the aortic isthmus has got a prognosis. When the CPR ratio becomes altered, or whether a reversal of flow in the aortic isthmus, it has been found out when they have followed the children at the age of 2 years, it has been found out that there was a delayed neurodevelopment. Okay, that carries the significance.
And the aortic isthmic flow is seen 2 weeks earlier to that of ductus venosus changes. So this is a very good prognostic value as well as in deciding. If many studies come on this, then that will be better. So you need to know much about aortic isthmic flow. So remember it. At least make a mention of it in your exam, right? Okay. More studies to come on that. Yeah.
Ma'am, umbilical artery PI is increased, ma'am, here. Then uterine artery Doppler PI is increased, and with the notching is also seen, ma'am, here. This is the middle cerebral artery.
What is the difference in uterine artery Doppler in the case of early onset FGR and late onset FGR?
Yes, ma'am.
What is that?
It is a very good predictor in the first trimester along with NT scan. Nowadays, it is being done in the between 11 to 13 weeks plus 6 days along with NT scan, ma'am. If the uterine artery PI is more during that time, we can start aspirin as early as 16 weeks. So it is uterine artery PI greater than 2.35 is an indicator of preeclampsia.
Take the PI of the right uterine, you're going to take the PI of the left uterine, and you're going to take
average. You are going to calculate, ma'am.
More than 2.35
is an indicator of preeclampsia.
Early onset of preeclampsia. And you're along with that, you're going to do an MAP.
Placenta associated plaque-protein and placental growth factor that will be decreased, and the alpha fetoprotein will be increased, and there will be increase of FCQ.
Alpha fetoprotein is not included. PAPA or placental growth factor, mean arterial pressure, risk
and maternal factors,
and uterine artery. That's all. All these 5 things. Don't bring the alpha fetoprotein here. Okay. These are the 5 things. And when this it has been increased, you're going to start.
It is
And also,
Nandini.
it reflects on the defective placental vasculation that takes place in the early onset. This does not happen in the late onset. The uterine artery may be normal throughout and suddenly it becomes abnormal in the third trimester. So some abnormality taking place that time can result in the late onset IUGR, and it is not associated much with preeclampsia. Whereas this one is more with the preeclampsia as well as bad vascularization. Yeah, vascular changes.
Okay. Nandini, tell me about the normal vascularization which occurs. Normally, what happens?
Yes, ma'am.
Here you told no umbilical artery is high resistance for more than the 95th centile. So what has gone wrong? What should have happened in the first trimester?
Ma'am, in the first trimester, the tropoblastic invasion should occur, ma'am.
Which period? That period is important.
Yes, ma'am. In less than 12 weeks, it should invade that decidual part of the uterine artery. Then after 12 to 16 to 20 weeks, it should invade the myometrial part of the spiral artery to decrease the peripheral.
Even before that, even before
both, 16 to 18,
so both waves of trophoblastic invasion should have been completed to convert a high resistance vessel
into a low resistant vessel and make it is a capacitance vessel, ma'am.
So only we cannot add aspirin in the later stages. So when we find, when we do the uterine artery Doppler and find a notching a high resistance flow, at that time no use of adding low dose aspirin. That's why we have to anticipate certain cases which may develop STA or okay. Now from your ultrasound study, what is the inference? So all the biometry shows
yes, ma'am.
Less than fourth centile, less than third centile. So it's a clear cut. Always you have to, with one ultrasound, you cannot go by the findings. So you have to again check the dates and again go by the first CRL measurement, and you have to correlate, and then you have to arrive whether she is really a case of IUGR. Now it's a case of early onset. It's a small fetus. So what could be the reasons for early onset IUGR?
In a case of how to differentiate it from a small for gestational age, ma'am? That constitutionally small fetus.
No. Now we have identified an early onset IUGR. So what and all could be the fetal causes for early onset IUGR? You told all the maternal causes.
Main thing of maternal causes will be of uteroplacental insufficiency, ma'am. Fetal factors like chromosomal or structural abnormalities, chromosomal like triploidy, trisomy 18, trisomy 13, then single gene disorders, then absent of umbilical artery, single umbilical artery. Then this is fetal, ma'am. Then maternal factors.
No, maternal you finished. I don't want maternal. Fetal also other things are there. All chromosomal
congenital fetal infections, ma'am. Fetal infections,
okay.
SARS infections, the most common is cytomegalovirus, rubella. Then
all these also
parasitic infections for early onset IUGR, ma'am.
IUGR, okay.
Yes,
considered as the intrinsic factors, ma'am. Okay, they are considered as the intrinsic factors, the congenital anomaly, the chromosomal anomaly, as well as the congenital infections. So 20% we can give rise to an early onset of IUGR when it is associated. Okay, having ruled out only, you have to talk about the consensus.
Epigenetic factors are important for early onset or late onset?
Ma'am, your voice is breaking. We could not hear, ma'am.
Epigenetic factors.
What
epigenetic factors? What is epigenetic factor?
Ma'am,
environmental factors.
Environmental factors. Yes, ma'am. Like, ma'am, high altitude, ma'am. High altitude of more than 5,000 feet. Then poor low socioeconomic status, and she's being not treated properly, like her poor weight. She's not being treated properly, like low nutrition, ma'am. These are the environmental factors, ma'am.
that constitutes that is
Smoking,
causing
caffeine,
Smoking also.
early
may
onset
not
or
be a
late
smoker.
onset.
early onset, no?
Okay. So now what are you planning to do? How is the management? Which is easy to manage? Early onset or late onset?
Late onset is easy to manage, ma'am, because already that they have crossed, they have a near term. So it is easy to manage, but difficult to diagnose, ma'am.
Okay. So what are you going to do for this lady?
Ma'am, since she is a case of gestational hypertension, I would like to advise her to get admitted in our hospital. Daily, I will like to monitor her BP. Then weekly, I will subject her for Doppler. Daily, I would like to do NST. Then I'll ask her to maintain the cardiac kick count. Then I'll explain to her what are the imminent signs and symptoms of preeclampsia. Then weekly, I will do all PIH investigation, and daily, I will do urine albumin, ma'am.
Okay, what are the
Ultrasound, how?
chances for early delivery?
Ma'am?
What are the chances for early delivery, and would you like to protect the
Very, yes, ma'am. There are chances for early delivery is more. So immediately, I would like to give one antenatal corticosteroids, ma'am, for lung maturity.
What is more important for these cases?
Ma'am, Maxels, ma'am, for neuroprotection, ma'am.
She gets into labor, intrapartum that is, not antepartum. Only when she gets into labor, the role of Maxels comes for neuroprotection.
Yes, ma'am.
Okay.
How are you going to? How long you will?
Weekly surveillance, ma'am. Weekly surveillance I will do.
So
Then
what interval you should do the ultrasound?
Ma'am, Doppler weekly. Growth, that is biometry, I will do 2 weeks once, ma'am.
Okay, and what are the parameters you will see in your biometry?
Biometry, ma'am.
What's the most important parameter?
AC, ma'am. Abdominal circumference.
What about biophysical profile here?
Yes, ma'am. Biophysical profile. Weekly, ma'am. Weekly I'll do biophysical profile also. If the NSC is daily, I will do NSC, ma'am. Weekly I'll do biophysical profile, ma'am.
What are the components of biophysical profile?
Ma'am, 5 things has been there in the biophysical profile: NSC, AFI, tone, breathing, and movements, ma'am.
Okay. Now tell me, when a fetus is put under a hypoxic insult, what is the gradual hypoxic theory? Which one will be the first to become a
Gradual hypoxic theory states that the first to appear in utero is the last to disappear, ma'am. At 8 weeks, tone appears. At 9 weeks, movements appear. At 20 weeks, breathing starts. Then fetal variability starts at 28 weeks. So if there is any hypoxic insult to the fetus, the heart rate variability will disappear first, followed by breathing, then movement, then the tone, ma'am.
So whenever the NST happens to be a non-reactive, you have to see at least the breathing movement.
Breathing movement is there or not. But I will do biophysical profile immediately, ma'am.
Is there any correlation between the biophysical profile and the suspected pH in the baby?
Yes, ma'am. If the baby is becoming more acidotic, that is, it will have decreased biophysical profile, less than 4, ma'am.
No, ma. If the biophysical
is reflected by what?
What will be the fetal cord pH? She is asking.
Reflected by which feature?
Fetal cord acidemia. What will be the relation of the biophysical profile to the pH she is asking?
Relation of biophysical, ma'am?
Profile and the pH.
To that of the pH of the baby.
Fetal pH.
If it is abnormal, it's acidotic.
Reflect
It will be less than 7.2.
7.2, isn't it? A lack of fetal tone could even mean a lesser pH.
So the biophysical profile is 4 and below.
It is less than 7.2, ma'am.
It will be less than 7.2. And when it goes to 2, almost 100%, the fetus will be acidemic. That is the thing of doing an importance of the biophysical profile. Now tell me whether the NST and the biophysical profile is a late sign or an early sign of hypoxia.
It is a late sign, ma'am, because the Doppler will precede at least 1 week before all this late signs, ma'am.
That is the reason we are picking up.
Always picking up.
by doing a Doppler study. Okay. Now tell me, you forget about your case of a gestational hypertension. Tell me, imagine it is a solitary case of an FGR. And which category, stage of Barcelona criteria she falls in?
Ma'am, she falls in mild placental insufficiency, stage 1, ma'am, because her because her umbilical artery PI is more than 95th and uterine artery PI is more than 95th, and she does not have any absent end-diastolic flow in the umbilical artery Doppler. So she belongs to stage 1, ma'am.
And the CPR is less than 5 percentile, and the uterine artery and the umbilical artery more than the 90. AC and the estimated feed pain less than the 3rd percentile. Okay, good. She falls under the stage 1. Then how you are going to follow her up?
Weekly, I will do Doppler, biophysical profile. Then I will see for
The
progression.
Doppler, you just tell me what vessels you are examining in the Doppler and significance of each. You have mentioned the umbilical artery. Now,
Umbilical artery Doppler, ductus venosus will see, ma'am. Because
then,
if there
wait, uterine artery, when a notching appears, it remains notched. Then next umbilical artery. Then which other vessel you want to examine?
Madam told
ductus okay, ma. One more vessel.
Aortic isthmus, ma'am.
No, one more vessel. Which important organ?
No, ma. When she says a CPR, you should say the middle cerebral artery also.
Middle cerebral artery, ma'am.
So middle cerebral artery, what happens? What is
ma'am, usually ma'am, middle cerebral artery is a vessel of high resistance, ma'am. There won't be any flow during normal thing, ma'am.
Yes.
So if there is any small for gestational age or IUGR, our body, the fetus will have cephalization of the blood flow. So middle cerebral artery pulsatile index will decrease to have diastole flow during diastole, ma'am.
So it supplies, main thing is it needs to supply the brain. So it's called as a brain sparing effect. Brain sparing effect. So like cerebroplacental ratio, one more ratio has come into vogue now. Yes, it may come into your recent advances also. What is that ratio called?
Ma'am, female length.
No. Like
ratio, ma'am.
Ratio.
Something like CPR.
Something like CPR. One more ratio.
Utro
plus. What is the recent one? Just like a CPR, what is that?
UPR.
UPR.
You
just note down and read out about that.
Okay, ma'am.
Okay. Now this lady, what are you going to do? How are you going to proceed? It's a difficult case because it's another risk factor. It's preterm. It's a preterm IUGR. So all preterm IUGR will have more adverse outcome. Okay. So,
yes, ma'am.
Actually,
I should try to balance between iatrogenic preterm and IUGR in utero, ma'am. So also this is a case of gestational hypertension. So I will monitor that she should not progress to severe preeclampsia, ma'am.
Okay.
All these features I will look after, and I will ascertain the appropriate time for delivery.
Okay. What is the role of aspirin and what is the role of L-arginine, hydration therapy? All you would have heard about, no? So what is the role of all that?
No role is there, ma'am. No role. Once established, there is no role in L-arginine, aspirin after 16 weeks, ma'am. Aspirin after 16 weeks is of no role. And L-arginine, zinc, calcium, vitamin D supplements for improving the IUGR. Even sildenafil has no role. Studies have proved that there's no role.
Okay, tell me what are the trigger factors for delivery?
Ma'am, trigger factors, ma'am. Severe preeclampsia with
forget the preeclampsia. If there's a maternal indication, yes, you're going to deliver. Tell me the fetal indications. Yeah.
Fetal indications. There is a reversal of umbilical artery, then ductus PI more than 95th centile, or this is the most triggering fetal factor, and reduce the fetal biophysical profile, ma'am, less than 4.
So before the reversal of ductus
PI. NST, no, what are you looking for in your NST, ma?
No, ma'am, biophysical profile, less than 4.
NST பண்ணுவேன்னு சொன்னல்ல. Daily NST பண்ணுவேன்னு நீ சொன்னியா இல்லையா?
Yes, ma'am, yes, ma'am.
What are you looking for in the NST?
In the variability, like non-reactivity, ma'am, in NST.
Okay, anything in the NST would make you deliver the baby quickly.
Saltatory pattern, ma'am.
Think and answer, ma.
Okay. Variable, ma'am, persistent variable deceleration, ma'am.
Think and answer. Uteroplacental
Late
insufficiency.
deceleration, ma'am. Late deceleration.
Late deceleration. There is no question of oligohydramnios. Where comes the variable deceleration here?
Okay, where does saltatory pattern come?
Repetitive decelerations should make you decide that you're going to deliver this baby. That is, apart from your Dopplers and your BPP, NST is also an indicator to deliver the baby quickly. This is what is commonly available. Many of us may not have your Doppler facilities. Okay. All right. Hello.
Yes, ma'am.
Audible?
Yes, ma'am. Yes, ma'am.
Okay. Okay.
Shall we ask the second presenter to present the case, ma?
Ma'am, if the externals accept, we can go ahead, ma'am.
Yes, ma'am.
Yes, ma?
Shall I start, ma'am?
Yes, ma.
Good evening, ma'am. I'll be presenting a case of IUGR. So here's a patient who's Mrs. X, 28 years old, wife of Y, belonging to low socioeconomic class. Class 4 according to modified Kuppuswamy classification, studied up to 5th standard, residing at Kirmampakam, Puducherry. She was referred from a nearest healthcare center, Nelikuppam PHC, which was about 2.5 kilometers from her residence. And she came to our hospital on 24/11/21 at 33 weeks plus 1 day gestation as a case of IUGR. She's Gravida 2 Paravan Liven, LMP is 5/4/21 and expected date of confinement is 12/1/22. She's a booked case of Nelikuppam PHC where she was referred to AVMC after she was suspected to be query SGR clinically. She was able to
Define UGR.
IUGR
What is
is
the
it is
definition? And what is the classification?
IUGR is when the fetus fails to attain its growth potential and estimated fetal weight is or the abdominal circumference is less than the 3rd percentile.
Third is severe IUGR.
What is the normal one?
Third is severe IUGR. Oh.
Ma'am, there is mild IUGR and there
No. What is
the percentile?
less than 3rd centile, ma'am. Less than 3rd centile, ma'am. AC or estimated fetal weight less than the 3rd percentile, ma'am.
That is a single diagnosis, ma. Other than that, less than the 10th percentile, you're going to
there are solitary and contributory. Contributory factors are abdominal circumference or estimated fetal weight.
No. Keep it simple. See, IUGR definition means less than the
10th
percentile or less than 2 standard deviation.
Okay. If the externals ask you in particular about the Delphi consensus, then you can go. Okay. Other than that, madam is asking you how you are going to define. You can just say, ma'am, if the estimated fetal weight or the is less than the 10th percentile. Then if you ask about the Delphi consensus, then you can say, ma'am, these are the single parameters. These are the contributory factors by which I'm going to say. Get your question and then answer.
Then what is the classification? What was the previous classification? Now how it is modified? Any idea?
Previously, it was symmetrical and asymmetrical IUGRs, ma'am. Now it has been late onset IUGR, ma'am.
Now it is based only on gestational age.
Gestation of 32 weeks, ma'am. Anything less than 32 weeks is early onset SGR and above 32 weeks is late onset IUGR, ma'am.
It is just an arbitrary cutoff. Okay.
Arbitrary cutoff.
Overlap can occur. Okay. So it is just an arbitrary cutoff. We are keeping 32 weeks. Okay.
Okay. I'll continue now.
Yes, madam. Says continue.
The patient is able to perceive fetal movements well. No history of abdominal pain. No history of bleeding or leaking per vagina. No other specific complaints. About the present pregnancy, the first trimester of spontaneous conception, which is confirmed by UPT at 6 weeks of gestation age. Dating scan was done at 9 weeks plus 4 days gestation, and the days were corresponding. No history of fever with rashes, no history of intake of drugs, no history of spotting per vagina, and folic acid tablets were taken. Already.
Okay, 1 minute. Any first trimester complaint correlates with IUGR?
Ma'am, if she's a threatened abortion with
so any spotting. Okay.
Yes,
another thing, the type of conception. Here you told spontaneous conception.
ART, ma'am. Artificial reproductive technique.
So that you have to. Okay. Then any UTI also, repeated urinary tract infections.
Okay. All routine investigations done in the PSC were within normal limits. So whatever history I'm taking is what details I got it from the PSC book, ma'am. And the deep C was done in the first trimester for screening and was found to be within normal limits, which is 110 milligram per dl. In the second
So how do you
trimester,
normally screen for diabetes?
ma'am, deep C is a standard screening method.
Tell the procedure.
Ma'am, at any given point of time, like
Ma'am, we'll stick to IUGR, ma'am. So much
Okay.
Irrespective of a last meal, 75 milligram of glucose is given to the patient, and after 2 hours, venous sample is being sampling withdrawn. is taken, and if it is greater than 140 milligram per day,
Okay,
it's labeled to
continue.
be a. Then second trimester, quickening was fed at 18 weeks of gestational age. No history of bleeding or leaking PV. No history of pain abdomen. 2 doses of TT injection was taken. Iron and calcium supplementation was given. BP recordings were normal throughout the pregnancy, and DIPSI was done at 24 weeks was also found to be within normal limits. And anomaly scan was done at PHC and was found to be normal. In the third trimester, the lady continued to perceive the fetal movement. No history of lower abdominal pain or bleeding or leaking PV. No history of breathlessness or edema of legs. At around 28 weeks, patient was diagnosed to have moderate anemia of around 9.1 milligram per dl, for which 4 doses of iron sucrose transfusion were done. Each time 200 milligram was given. Patient went to a PHC for routine antenatal checkup at around 33 weeks. There, the medical office examiner, by clinical examination, suspected it's a case of fetal growth restriction and referred to us for further management. Coming to the past obstetric history, it's a spontaneous conception. Antenatal period was uneventful, no history of PH or GDM in the past, and it was a full-term normal vaginal delivery. And the female baby was delivered at Kadlur GH, weighing about 2.7 kg. The baby is active and healthy and about 2.5 years of age, and no contraceptive was used. And the present pregnancy, she conceived spontaneously 8 months after her first delivery. Coming to the past medical history and surgical history, no significant surgery in the past, no history of any bronchial asthma or epilepsy. Marital history, she is married since 3 years and it's a non-consanguineous marriage. Menstrual history, the menarche is around 14 years and LMP is 5421 and it was a regular cycle with average growth. Family history, no history of any diabetes, hypertension or twins. Personal history, diet, she is a vegetarian, bowel and bladder movements normal and regular, appetite normal. Sleep pattern normal, no history of active or passive smoking, alcoholic or any drug abuse. General physical examination, on examination BP fair, afebrile, moderately built and nourished. A pre-pregnancy weight was 51 kg and a BMI of about 21.25 kg meter square, and at present pregnancy at around 33 weeks, her BMI is 24.2 kg per meter square and net weight gain during present pregnancy is 6.5 kg. She is not anemic at 33 weeks, pulse rate 86 beats per minute, BP 110/70. Thyroid no enlargement, soft non-tender, bilateral soft non-tender, nipple normal, no icterus lymphadenopathy, cyanosis, clubbing of fetal edema. Husband details, he was also average height and weight man with a BMI of 25 kg per meter square. On systemic examination, serious F1, present, no murmur, RS bilateral normal club that sounds present. On abdominal examination and inspection, abdomen uniformly enlarged, linear nigra and striatum present. No scars or dilated veins or hernia and annual orifices are free. Under palpation, the symphysis fundal height was about 30 centimeter, abdominal girth 72 centimeter, and a uterus corresponds to about 30 week size. Fundal grip, soft, broad, irregularly non-palatable part, suggestive of breech. Umbilical grip on the left side, a convex, smooth, resistance felt, suggestive of spine, and the limbus on the right. First pelvic grip, fetal head felt in the lower pole and is mobile, and SHR 140 beats per minute on the left side. And clinically, LICA was adequate. And when she came here, we did our basic general investigations. Her HP was found to be 10.1 and the PCV was 29. And all routine investigations were within normal limits. And after she came to us, we did an ultrasound with Doppler at 33 weeks plus 1 day gestation, which showed a single live intrauterine gestation corresponding to 30 weeks plus 1 day gestation with good fetal cardiac activity. Placenta posterior and AFI was normal 9 to 10. Estimated fetal weight was 1055 plus or minus 214 gram, which is around 5th percentile. AC corresponds to 28 weeks plus 2 days, which is around 7th percentile. And the other parameters were within normal limits. Umbilical artery Doppler, umbilical artery PI was also within normal limit. MCA PI was also within normal limit, and CPR was greater than 1. So in this ultrasound, the estimated fetal weight was in the 5th percentile, and abdominal circumference was 7th percentile, and there were no Doppler changes. So at this point, I didn't come to a conclusion that it is a SGR. But since the patient, this is the, according to the ultrasound finding, this is the umbilical artery PI, which is normal, and this is the middle cerebral artery where the CPR is greater than 1. Provisional diagnosis is 28-year-old, gravida 2, para 1, lichen, normotensive, euglycemic with no previous history of FGR. Referred from a PhD at 33 weeks plus 1 day gestational age as a case of query FGR with having undergone treatment for moderate anemia at 28 weeks gestation. Ma'am, I'll go with the course of the hospital. Hello?
Yes.
No.
I'll continue, ma'am.
Rajalakshmi?
Rajalakshmi is asking you something. Yeah.
No. At this point of time, do you think her weight gain was adequate?
No, ma'am, her weight gain was
Because
not
she's been seen by somebody else and she has come to your hospital. Okay. So throughout her pregnancy, was her weight gain adequate?
No, ma'am. Only she's gained about 6.5 kg, which is not adequate.
What should have been her weight gain?
Ma'am, if you consider 1, 6, 7, almost about actually in the full 11 kg she should have gained, ma'am.
11 kg. Okay, what is the growth lag?
Growth lag is when the
As per her
less than 6
gestation
weeks,
age, no, as per her gestation age, what should have been her gestation age now?
Symptoms
What is
of
the lag?
height should have corresponded to
the gestation age, ma'am.
but here the difference was more than 3 centimeters. Here it is 30 centimeters.
So
ma'am.
2 weeks lag.
3 weeks.
3 weeks lag, ma'am.
3 weeks lag.
Yes,
Okay.
ma'am.
3 weeks lag with Leica is AFA is adequate.
It is adequate, ma'am.
Adequate and Doppler parameters
Are within normal limits.
or normal. Okay. So
Yes,
now what would you like to do?
Ma'am,
Nikita,
yes,
Nikita,
yes, ma'am.
can you go to the ultrasound picture that you were showing? No, not picture, the report, Yeah. See, can you spot one gross mistake in this report when you look at it?
She is 33 weeks plus 1 day gestation. The single vertical pocket, ma'am.
No, ma.
See, the patient is 33 weeks plus 1 day. This gestational age has been assigned as per
LMP, ma'am.
LMP, as per the LMP.
LMP and probably confirmed with her first ultrasound. She had a first trimester ultrasound, isn't it?
Yes, ma'am.
So at this point of time, you should not give a gestational age as 30 plus 4. Her gestational age will be assigned as per the LMP, and you have to tell that, that's how they're supposed to be reporting. All right. They are not supposed to be giving a gestation of 30 plus 4. They should say the gestation age is assigned as per her LMP. Or as per a first trimester ultrasound, but the growth corresponds to only 30 plus 4 weeks.
4 weeks. Okay, ma'am.
Okay.
Yes, ma'am.
Right.
Patient was referred from a nearby PhD suspecting FGR, and the patient was admitted in our hospital on 24/11/21. That is when she was 33 weeks plus 1 day gestation, where abdominal circumference was under the 7th percentile and estimated fetal weight was at the 5th percentile, when the Doppler was showing no changes. So at this point, we gave corticosteroids, 4 doses of 6 mg injection dexamethasone was given 12 hours apart, and a daily fetal kick charting, NST daily and weekly biophysical profile was
How do you do the fetal kick count?
Ma'am, she was she was counseled to check for minimum of 10 counts, ma'am, in between the 12 hours period. It is very long, but rather than we can ask the patient after every meal, in the next 1 hour, she should count the fetal movements, ma'am. Food after food. Yes, ma'am. There should be at least 3 movements to say that is 1 hour, ma'am.
In 12 hours, there should be at least 10 movements.
10 movements.
Okay. Can you tell something about now this patient? We are just going to keep her under observation. We are doing all the evaluation, and next what we are going to do? We have to look for interval growth.
Yes, ma'am. Actually, in this patient, fetal kick charting was done, NST daily and weekly biophysical profile, ma'am.
Can you tell something about?
See for the growth.
Okay. Can you tell something about the fetal growth charts?
Gravidogram we will like to plot, ma'am.
Okay.
They have given the growth chart, no?
Yes, ma'am. Yes, ma'am. Along with the
This
is the
growth centile curves, ma'am. We will see whether the growth velocity is maintained or static or it is decreasing.
Ma'am, in this case, it's a case of why I'm telling it's a case of FGR is
What are the centiles for other people who are in the audience? No, you just tell the centiles.
Ma'am,
And you
there
can
is
just
10
tell.
centiles and there is 90 percentile, ma'am. And if a fetus, normal fetus will be above 90 percentile, any 50 percentile, anything below 10 percentile is considered small.
Nikita, your voice is breaking. Your voice is breaking. So,
Ma'am, can you hear me?
if it is less than the 10th percentile, you are going
Small for gestational age.
If it is more than the 90th percentile, it is
LGA, large for gestational
If
age.
it is between 10th and
Average for
90th, you are
gestational
going
age.
to say average for gestational age. Okay.
So
what
anything below 10% is small for gestational age, ma'am. In this, we have plotted the weeks.
Yeah, you have plotted. See how will the chart for an IUGR and how will the chart for an SGA look?
Ma'am, in case of SGA, here I've plotted here. This is a case of IUGR, ma'am, where after it won't in IUGR it won't attain its own growth velocity curve, ma'am. Here it's reached and it's become flat. Whereas in case of a SGA, it will attain its own growth potential. And it will maintain the velocity, ma'am.
Velocity is maintained, so that is the main difference. Okay. And Doppler indices are also normal in the case of an SGA. Okay. Now, lady, we can wait, and then how long you can wait, and what are the trials, recent trials?
Ma'am,
for IUGR?
recent trials, we have a digital trial.
Tell all the trials and what was the outcome.
Grid trial, starting from grid.
Nikita, I want to ask you one more question. In late onset of IUGR, will there be any absent flow or reversal of flow in the umbilical?
No, ma'am, it won't be there.
Or there will be any ductus venosus Doppler change?
Nothing, ma'am. No, ma'am. It will only, CPR is the only criteria by which
So you have to emphasize there won't be any absent or a reversal of flow in the umbilical artery, or the ductus venosus changes will not occur in late onset because in late onset there is no cardiovascular adoption. Okay. Why in late onset of IUGR there is no absent flow?
Because the brain stem is already sensitive. It is already formed.
No, one of you speak. One of you speak. Both of you speak together.
The brain stem is already formed in late onset IUGR, ma'am. So it is very sensitive to hypoxia. It is very sensitive to hypoxia, ma'am.
Whereas in early onset of IUGR,
it is resistant to hypoxia.
Preterm babies, the brainstem is resistant to hypoxia. And that is the reason why you are seeing all these changes. First, there will be an umbilical artery increase PI. The middle cerebral artery PI will become less than percentile. Then the CPR
absent and reversal flow.
Then there will be an absent flow. Then there will be a reversal of flow in the aortic isthmus. Reversal of flow in the umbilical artery.
That is PI greater than 94th percentile.
Gradation of events will take place only in early onset of IUGR. This we have to emphasize for the PGs. In late onset of IUGR, you can't just say there is no absent flow, there is no reversal of flow in the umbilical artery. So I'm taking it for granted that the fetus is alive, he will be hale and healthy. No, it won't be like that. CPR ratio will be altered. And finally, what will happen? The baby will go in for a sudden intrauterine stillbirth. So you have to monitor the biophysical profile and NST. The Doppler changes of absent or reversal of flow in the umbilical artery and the ductus venosus changes will not take place in late onset. We have to emphasize.
Okay.
Nikita, I have another question for you. What is the role of steroids in late FGR?
No, up to 36 weeks, according to RCOG, we can.
Yeah, what is the controversy related to that?
Yes, ma'am, it can lead to, it has also has negative effects, ma'am. It can lead to intraventricular hemorrhage. Ma'am, it will have hypoxic in the gray metals, ma'am.
Can affect the gray matter of the brain.
Can affect the, affect myelination. All right. Okay,
you were telling about the trials, no?
Not to give beyond 34 weeks.
Okay, you just started telling about the
grid digital trial, ma'am. Disproportionate intra-growth restriction intervention trial, ma'am. Here they'll be comparing the induction versus the expected
management. Okay.
management at terms, ma'am. There the selected group is 36 weeks plus gestational age with IUGR, ma'am. Actually, there was no much difference found between
difference. Okay.
between
Other
trials. Photo trial, ma'am. It is a prospective observational trial to optimize the pediatric outcomes, ma'am. In this, the participants included were estimated fetal weight or abdomen circumference less than the 10th centile, with or without Doppler changes, without oligohydramnios, ma'am. They all studied these participants, and then their outcomes were evaluated. And the conclusion was the people with estimated fetal weight or abdominal circumference less than 3rd centile or umbilical artery PI more than 94th centile, they had adverse outcomes, ma'am. Then next is grid trial, ma'am. Growth restriction intervention trial. It will decide the time of delivery and the outcome, ma'am. Here it was the two groups were early or deferred time of delivery was there. There was no much significance here also. Both had adverse outcomes, ma'am. Both the groups.
I have got in the chat box, someone has asked, can you repeat the hypoxic resistant in preterm? I'll repeat it. In preterm babies with an IUGR, the brain stem is resistant to the hypoxic insult. So the preterm baby has got time to accommodate itself. So there comes your question. The placenta has got two surfaces, the fetal surface and the maternal surface. The fetal surface is supplied by the maternal surface is supplied by the uterine artery, and the fetal surface, you are seeing the umbilical artery. So the uterine and the umbilical artery, they are taken as an indicators of placental function. The fetal function is done by the middle artery and the ductus venosus. Okay. Now, a preterm fetus, when it is exposed to the hypoxic insult, what happens? It has got sufficient time to accommodate for that insult. So what it does, there is a catheterization of the blood flow. You all know the middle cerebral artery is a vessel of high resistance. There will be flow only during systole and no flow during diastole. If there is a flow during diastole in the middle cerebral artery, it is pathological. If there is no blood flow in the umbilical artery during diastole, it is pathological. So because umbilical artery is a vessel of less resistance, low resistance. So what happens? The fetus tries to compensate for the hypoxic insult, and there is a brain sparing effect. So the middle cerebral artery receives more blood, and there is a blood flow during diastole. And after that, what will happen? There will be an absent flow in the umbilical artery. You all know the umbilical artery. Just put that last slide, ma, which I can show. The umbilical artery flow. The umbilical artery has got a systolic and a diastolic. That figure alone. No, ma. That is the last one.
Yes, ma'am. Yes, ma'am. Putting, ma'am.
Just for the sake of the you just show the umbilical artery. Yes, ma'am. Here the umbilical artery, this has got a systolic flow, this has got a diastolic flow. The systolic flow indicates the fetal cardiac output because the umbilical artery arises from the fetus. The diastolic, the umbilical artery, it branches out and finally it enters in the tertiary villi. So the blood flow in the tertiary villi will be seen by the diastolic flow. Okay. When 40% of the terminal villi is not doing its function properly, there will be an increase in the PI of the umbilical artery. When 60% of the terminal villi is not doing its function, there will be an absent flow. If there is a reversal of flow, it indicates that 70% of the terminal villi is not doing its function properly. A late onset of IUGR, it is a disease of mild placental insufficiency. So the umbilical artery Doppler will not be picked up by the late onset of IUGR. Okay. And the preterm fetus will have, first there is a catheterization. Then there will be an absent flow, a reversal of flow. And finally, you show me the ductus venosus Doppler. Here, the ductus venosus Doppler, you know the ductus venosus has always a forward flow because the ductus venosus goes and opens into the right atrium. The pressure in the ductus venosus will be always greater than the pressure in the right atrium, even during the cardiac systole. When the fetus myocardial ischemia has come and the fetal heart is not pumping, the right atrial pressure becomes high. So when the right atrial pressure becomes more than the ductus venosus pressure, there is a reversal of flow, which means there is an impending cardiac failure. Myocardial ischemia. There comes your question of the reversal of flow in the ductus venosus. These changes all will take place only in early onset of IUGR because the preterm fetus is resistant to the hypoxic insult, and so it adjusts itself to the maximum effort. There is an alteration in the middle cerebral artery, the CPR ratio gets altered, then comes your absent or the reversal of flow in the umbilical artery, then comes your ductus venosus, increased PI, reversal of the flow in the ductus venosus. But in a late onset, already 32-34 weeks has occurred, the brainstem is sensitive to the hypoxic insult and the fetus heart cannot compensate. So there will not be any absent flow or a reversal of flow in the umbilical artery. No ductus venosus changes will occur in late onset of IUGR, and only the CPR ratio will be altered in late onset of IUGR. It indicates there is a mild decrease in PI in the middle cerebral artery and a slight increase in the PI in the umbilical artery. This for the PGs I want to emphasize. For the late onset of IUGR, the decision must be taken only.
Okay. What is the role of CC?
Roll off, ma'am? We couldn't hear you, ma'am. Roll off, ma'am.
I'm not audible. Roll off.
Computerized CTG.
Computerized CTG.
Ma'am, in India it is not available, ma'am. Actually, the truffle trial, the short-term variability, ma'am, is indicator in a case of a computerized CTG, ma'am. In between the gestational age of 26 to 29 weeks, more than of 2.6 milliseconds variability is considered as abnormal. And between 32 to 32 weeks, more than 3 millisecond short-term variability is considered as abnormal, ma'am.
It is the RR interval, ma'am. That is,
yes, ma'am. That is the RR interval.
That is the short-term variability. What we are doing on our ordinary CTG is the long-term variability.
Long-term variability. Long-term and the short-term.
Okay. As we
now, Madam has nicely explained clearly about the Doppler changes. And actually, late onset IUGR is more dangerous. We have to, we should anticipate and patient should be under observation. See, now one more thing, in PHCs and all, we don't have Doppler facilities. So how will you educate your VHNs and all, how to follow up the case? How to they have to identify, no?
Yes,
so what tool you will advise? A simple
gravidogram, ma'am.
Gravidogram, okay. And latest you told about sildenafil. One more therapy is under research.
Everest trial.
So vascular. Gene therapy.
Gene therapy.
So
yes,
that also is under trial.
Yes, ma'am.
I think both of you presented
very
well and answered well. Both of you and covered, and my other co-examiners covered all the aspects. But it is whatever it is for you to apply.
Thank you.
Thank you, ma'am. Thank you so much.
Ma'am, can you stop sharing, ma'am? We can see everyone.
Very nice.
Stop sharing, ma'am. Sorry, ma'am. Yes, ma'am.
If you stop sharing, we can see.
Students, Shashikala, your students did very well.
Thank you, madam. Thank you.
Shashikala, madam, as of now, we have 450 registrations.
Oh.
This is the maximum registrations in our Bodhana.
Okay.
Bodhana.
Thank you, madam.
Very happy to see Anjalakshmi madam and Sampath madam, both my teachers. Jayashree madam, all were excellent. Both of them were my teachers.
ஜெயஸ்ரீ மேடம் மலை மேல இருந்தாலும் அழகா எடுத்துட்டாங்க.
எங்க இருக்காங்க? When she's traveling somewhere.
திருப்பதி.
Oh, okay.
Because
சசிகலா மேடம் சான்ஸே இல்ல சசிகலா மேடம்.
Sampath Kumari, because of your inspiration, I have made my students to. Okay.
Fantastic presentation and fantastic answering. நல்லா படிச்சிருக்காங்க பசங்க. அதுதான் நம்மளோட purpose.
Thank you, Ma, for participating.
Thank you, ma'am. Thank you, ma'am. As usual, you have trained them so well that they answered so well, ma'am.
Thank you, Ma. Thank you.
Okay.
Thank you, ma'am.
சசிகலா மேடம், ஜெயஸ்ரீ மேடம் அண்ட் ராஜலட்சுமி மேடம், செந்தில் மேடம் எல்லாரும் ஒரு செம எக்ஸாமினர். IUGR என்னைக்கும் உங்களுக்கு மறக்காதுன்னு நினைக்கிறேன் இனிமே. ஓகே.
Thank you very much, ma'am. Thank you for the opportunity, ma'am.
Thank you, ma'am.
Kalpana, do you want to tell anything? Anjalakshmi madam?
Thank you.
Thank you, madam. Fantastic.
Thank you.
Thank you, ma'am.
Thank you, Sasikla.
Bye.
Kita, எல்லா ப்ரோக்ராம்லயும் அட்டெண்ட் பண்ணுங்க. நான் every second Saturday and fourth Saturday we will be having. I'll post in the group. Okay. Thank you, Raji madam. Thank you all.
Thank you.
And they can give their opinion, Sampath.
என்ன மேடம்?
Give their opinion.
யார் பசங்களா? நிக்கிதா, you can give your opinion. Do you want anything to improve?
Sampath பயங்கர energetic motivator.
ஆமா.
It is a good friend.
It will be a real motivation for other students also.
MCQs மாதிரி கொடுப்பான்.
Nikita, Nandini, do you want to tell anything?
Ma'am, it is purely our based on our moderator.
Or we can post test மாதிரி some
Yes.
not for you, next to the suggestion.
சரி, feedback questionnaires இனிமே போடலாம். நல்லா பசங்க நல்லா prepare பண்ணியிருந்ததுனால it was really interesting. செந்தில் madam, thank you.
Thank you, ma'am. Thank you.
Okay, we'll break. Thank you.
Yes, we can leave. Chitrakala, shall we close?
Yes, ma'am.
Thank you, Chitrakala. Kalpana, thank you.
Thank you, ma'am.